Welcome to the deep dive. Today we're doing a focused run-through of deep vein thrombosis, specifically geared towards smashing the MSRA.
Yeah, exactly. We're aiming to pull out all the high-yield stuff you absolutely need to know about DVT.
Think of this as your quick, efficient revision session. Our mission: make DVT knowledge stick.
Let's dive in.
Okay, so starting right at the beginning, what actually is DVT, the core definition?
Right. So DVT, deep vein thrombosis, is essentially a blood clot. It forms in one of the deep veins, usually, down in the legs.
And the main problems it causes.
Well, two big things. First, it blocks the vein, obstructing blood flow back to the heart. And second, the really dangerous bit is that part of the clot can break off and travel.
The pulmonary embolism risk.
Precisely. That's the major concern. And remember, DVT falls under the umbrella term VTE, venous thromboembolism.
Okay, VTE. Got it. So what causes it? What's the underlying mechanism we need to understand?
The absolute classic here is Virchow's Triad. You really have to know this. It's like the cornerstone for understanding why DVTs happen.
Virchow's Triad. Okay, sounds important. What are the components?
Three things. First, venous stasis. That just means blood flow is slow or sluggish.
Like pooling.
Exactly. Think about being immobile for a long time, long-haul flight, bed rest in hospital. Blood isn't moving well.
Okay, stasis. What's number two?
Number two is hypercoagulability. Basically, the blood itself is more prone to clotting than usual.
And why might that happen?
It can be inherited, genetic factors, or it could be due to other things like cancer, certain inflammatory conditions, even some medications like hormone treatments.
Right, so thicker, stickier blood, in a way. And the third part of the triad?
Endothelial damage. This means there's some injury or inflammation to the inner lining of the blood vessel wall itself.
How does that happen?
Could be from surgery, direct trauma, maybe even just inflammation near the vein. That damage sort of kicks off the clotting process locally.
So slow flow, clot-prone blood, and vessel wall injury. Those three together are bad news.
That's the perfect storm for a DVT, yes.
Okay, that triad makes sense. Now, building on that, what are the specific risk factors we should be looking out for in patients, the common triggers?
Yeah, there's a well-established list. We mentioned prolonged immobility or travel. Hospitalization, that's a big one.
What else?
Recent surgery or major trauma is significant. Increasing age is definitely a factor. Having a personal history or even a family history of DVT or PE really bumps up the risk.
Makes sense. Anything related to lifestyle or other conditions?
Yes. Obesity is a known risk factor. Pregnancy and the period just after giving birth, the postpartum period. Also, hormone therapy, so things like the combined oral contraceptive pill or HRT.
And underlying diseases.
Definitely. Active cancer is a major risk factor. Also, certain chronic inflammatory diseases can increase the risk too. Basically, anything that tips the balance towards one or more parts of Virchow's Triad.
Okay, quite a comprehensive list there. So let's imagine it happening. Can you walk us through the pathophysiology?
Yeah.
How does that clot actually form?
Well, it starts with those risk factors promoting, the slow blood flow. Maybe the blood being a bit hypercoagulable, perhaps some subtle damage to the vein lining.
Right, the triad in action.
Exactly. And this creates an environment where the body's clotting cascade gets activated inappropriately within that deep vein. Platelets start sticking, and then fibrin forms a mesh.
And what's the clot mostly made of?
Primarily fibrin, that's the protein mesh and platelets that get trapped within it, along with red blood cells.
Okay, so this clot builds up. What happens then, locally and potentially systemically?
Locally, it can partially or even completely block the vein. That causes the symptoms like swelling and pain because blood can't get back up the leg properly.
And systemically.
That's the PE risk again. If a piece breaks off, we call that an embolus. It travels up through the veins, through the heart, and can get lodged in the pulmonary arteries in the lungs. That's a pulmonary embolism, and it can be fatal.
A really critical point. Now, someone comes in with a painful, swollen leg. DVT is high on the list, but what else could it be? What are the main differential diagnoses?
Good question. It's vital not to miss a DVT, but other things can look similar. Superficial thrombophlebitis, clotting in a vein closer to the skin is one. Usually less serious, but can be painful.
What about infections?
Cellulitis, yeah, a skin infection. That causes redness, swelling, warmth, often pain too. But you might also get systemic signs like fever, which are less typical for DVT alone.
Any musculoskeletal causes?
Sure. A muscle strain, particularly in the calf, or a hematoma, a collection of blood from an injury, can mimic it. History of trauma or exertion might point you that way.
Okay. Anything else common?
You might think about arterial insufficiency, though the leg is often cool and pale then, rather than warm and red.
Hmm.
A ruptured Baker's cyst, that's a fluid-filled sac behind the knee, can cause sudden calf swelling and pain. And maybe lymphedema, which is swelling due to lymphatic system issues, but that's often more chronic and sometimes affects both legs. So you need to consider the whole picture of the history, the exact signs.
Very helpful. So, thinking about the UK specifically, how common is DVT? What's the epidemiology look like?
The estimates are around 1 to 2 cases per 1,000 people each year in the UK. So, it's definitely something clinicians will encounter reasonably often.
Does it affect certain groups more?
Yeah, the incidence goes up quite significantly with age, and studies suggest it's slightly more common in men than women. Overall, it occurs both in hospitals and out in the community setting.
Okay, so fairly common, increases with age. Now, the clinical presentation. What are the classic signs and symptoms we're taught to look for?
The typical picture is usually unilateral, just one leg. You're looking for leg pain, tenderness, especially when you press along the line of the deep veins. Swelling is common, often pitting edema.
Anything else visually?
The leg might look red, feel warm to the touch compared to the other leg. Sometimes you can see the superficial veins becoming more prominent or dilated because the deep system is blocked.
Does movement affect it?
Often, yes. The pain might get worse with walking or even just flexing the foot upwards, Hoeman's sign, though that's not very reliable.
Is it always obvious?
No, definitely not. And this is crucial. Maybe up to half of people with the DVT might have very minimal symptoms, or even none at all, which is why assessing risk factors is so important. You might investigate someone based on risk even with subtle signs.
Right, the silent nature is quite worrying. So you suspect DVT based on risk factors and maybe some symptoms. What investigations do you use to confirm it?
The main investigation, the sort of gold standard non-invasive test, is a compression ultrasound scan of the leg veins.
How does that work?
They use the ultrasound probe to directly look at the deep veins and actually try to compress them. A normal vein compresses easily. If there's a clot inside, it won't compress. They can literally see the thrombus sometimes.
Okay, ultrasound first line. What about the D-dimer test? Where does that fit in?
D-dimer. It measures breakdown products of fibrin clot. So if you have a significant clot forming or breaking down, your D-dimer level will likely be high.
So a high D-dimer means DVT.
Not necessarily. That's the key thing. It's sensitive, meaning it's usually elevated if there is a clot, but it's not specific. Loads of other things can raise D-dimer infection, inflammation, surgery, pregnancy, cancer.
So how is it useful then?
It's mainly useful as a rule-out test. If your clinical suspicion is low based on something like the Wells score and the D-dimer is negative, you can be pretty confident the patient doesn't have a DVT.
Right, it helps avoid unnecessary scans in low-risk patients. Are there other imaging tests?
Occasionally, things like contrast venography, injecting dye, or MR venography might be used, maybe if the ultrasound is inconclusive or looking for clots in unusual places, but they're generally second line. Ultrasound is the workhorse.
Okay, now, NICE guidelines are obviously key for the MSRA. They have a specific pathway using the Wells score, right?
Absolutely. The NICE guidance from 2020 recommends using the 2-level DVT Wells score first to stratify patients based on their clinical probability.
Can you remind us how that works?
Yeah, it assigns points for various clinical features: active cancer, paralysis, or recent plaster cast, recent bedridden 3 days or major surgery 12 weeks, localized tenderness, entire leg swollen, calf swelling 3 centimeter difference, pitting edema, collateral superficial veins, and importantly, it subtracts 2 points if an alternative diagnosis is as likely or more likely than DVT.
Okay, you add up the points, then what?
If the score is 2 points or more, the patient is considered DVT likely. The guideline says they should get a proximal leg vein ultrasound within 4 hours.
And if that scan is positive?
Start treatment, anticoagulation. If the scan is negative, you then do a D-dimer test. If the D-dimer is also negative, DVT is considered unlikely.
What if you can't get the scan done within 4 hours for a DVT-likely patient?
Then you should do the D-dimer test and start interim therapeutic anticoagulation, usually with a DOAC, while awaiting the scan, especially if the D-dimer is likely to be positive.
Okay, that's the likely pathway. What about if the Wells score is 1 point or less, DVT unlikely?
For the DVT unlikely group, you start with the D-dimer test, again, ideally within 4 hours.
If that's negative?
DVT is unlikely, stop anticoagulation if it was started, and think about other diagnoses.
And if the D-dimer is positive in this unlikely group?
Then they do need the proximal leg vein ultrasound within 4 hours. And again, if there's going to be a delay getting the scan, you should offer interim anticoagulation.
That's a very clear pathway. Anything specific NICE says about the D-dimer test itself?
Yes, they mention using either lab-based or validated point-of-care tests. And importantly, for patients over 50, they recommend using age-adjusted D-dimer thresholds.
Why is that?
Because D-dimer levels naturally tend to increase with age. Using an age-adjusted cutoff makes the test more specific in older people, meaning fewer false positives and fewer unnecessary scans.
Crucial point for practice.
Okay.
So we've used the well score, done the tests, confirmed the DBT. What are the main aims of management in the UK?
The primary goals are straightforward. Stop the clot getting bigger, prevent it embolizing to the lungs, PE, and reduce the risk of it coming back later on.
And how do we achieve that? What are the main treatments?
Anticoagulation blood-thinning medication is the absolute cornerstone of treatment. Alongside that, advice usually includes things like leg elevation when resting, wearing compression stockings in some cases, and avoiding long periods of immobility.
Let's focus on the anticoagulation. That's changed a bit over the years, hasn't it?
Massively. Warfarin used to be the standard for decades, requiring regular INR blood tests and careful dose adjustments. But now, the direct oral anticoagulants, the DOACs, are generally recommended first line for most patients.
Which DOACs are we talking about?
Apixaban and rivaroxaban are often used initially, as they don't typically need bridging with heparin. Dabigatran and edoxaban are other options, but they usually require an initial course of heparin like LMWH first.
And why the shift to DOACs?
They're generally just as effective, if not more so in some studies. They have a lower risk of major bleeding, particularly intracranial hemorrhage compared to warfarin, and crucially, they don't need routine monitoring. Much more convenient for patients.
Are there situations where DOACs aren't the first choice, or specific patient groups needing different approaches?
Yes, there are exceptions. For instance, if DOACs are contraindicated or not suitable for some reason, the alternative might be low molecular weight heparin, LMWH injections, followed by dabigatran or edoxaban, or LMWH followed by warfarin, aiming for the usual INR target.
What about patients with cancer?
For active cancer, DOACs are now often preferred over LMWH based on recent evidence, unless there are specific contraindications like drug interactions.
Any other specific groups?
Patients with severe renal impairment, kidney problems often need dose adjustments or might be better suited to LMWH, unfractionated heparin, or LMWH followed by warfarin. And for patients with antiphospholipid syndrome, warfarin is generally still the preferred long-term anticoagulant after initial heparin.
Okay, that covers the choice. How long do people typically need to stay on anticoagulation?
The minimum duration for any DVT is usually 3 months.
Just 3 months.
For a provoked DVT, meaning it was clearly caused by a transient risk factor like recent surgery or immobility that's now resolved, then yes, 3 months is often considered sufficient. Although for active cancer, it's often 3 to 6 months.
And what if it was unprovoked? No clear reason for it.
For an unprovoked DVT, treatment is typically longer, usually continued for a total of 6 months. The decision on duration beyond 3 months always involves weighing up the individual's risk of the DVT recurring versus their risk of bleeding while on anticoagulants.
So it's a balance.
Exactly. For provoked DVTs in people with a low bleeding risk, NTI suggests considering extending to 6 months too. It's an individualized decision after that initial 3-month period.
Right. So assuming patients get the right treatment promptly, what's the general outlook? The prognosis?
Generally, with appropriate anticoagulation, the prognosis for DVT itself is good. Most people respond well, the clot stabilizes and starts to break down, symptoms improve, and the immediate risk of PE drops significantly.
That's reassuring. But are there potential longer-term issues or complications even with treatment?
Yes, unfortunately. While treatment is effective, complications can still occur. We've mentioned PE, the most serious, acute one.
What about chronic problems?
A significant proportion of patients can develop post-thrombotic syndrome, or PTS. This is chronic venous insufficiency resulting from damage to the vein valves by the clot.
What does PTS look like?
Symptoms can include persistent leg pain, aching, heaviness, swelling, and in severe cases, skin changes like pigmentation, eczema, and even venous ulcers. It can really impact quality of life.
Anything else?
There's always a risk of recurrent DVT or PE, even after finishing treatment, particularly if it was unprovoked. And the chronic venous insufficiency from PTS can lead to ongoing problems with blood flow, chronic edema, and potentially those difficult-to-heal leg ulcers.
So it sounds like while the acute phase is manageable, The long-term consequences mean prevention and optimal management are really key.
Absolutely. Recognizing those risk factors early, diagnosing quickly using the proper pathways like the Wells score and imaging, and getting patients onto effective anticoagulation promptly is crucial to minimize both the short-term PE risk and the long-term complications like PTS.
Okay, great. Let's just quickly recap the absolute essentials from this DVT deep dive for MSRA revision.
Yeah, so definition. Clot in a deep vein, PE risk. Etiology. Virchow's Triad stasis, hypercoagulability, endothelial damage. Know those risk factors: immobility, surgery, cancer, age, hormones, etc.
Pathophysiology. Triad leads to clot formation, fibrin, platelets, differentials, cellulitis, Baker's cyst, muscle tear. Epidemiology. 1 to 2 per 1,000 per year in UK, rises with age.
Clinical features. Unilateral leg pain, swelling, warmth, redness, but can be minimal. Investigations. Wells score first, then D-dimer and/or compression ultrasound depending on score. Remember the NICE pathway.
Management. Anticoagulation is key. DOACs, apixaban, rivaroxaban, usually first line. Duration. Minimum 3 months, often 6 months for unprovoked. Consider specific groups like cancer, renal impairment.
Prognosis. Generally good with treatment. Complications. PE is the big acute one, post-thrombotic syndrome is the main chronic one, plus recurrence risk and chronic venous insufficiency.
Fantastic summary.
Right.
Remembering that structure definition to complications and the key points within each, like Virchow's Triad and the Wells pathway, is exactly what you need.
Definitely high-yield stuff.
So as you continue studying, really lock down this DVT knowledge. A clear understanding is much better than just memorizing facts.
And don't forget, for loads more brilliant MSRA revision materials, practice questions, and more deep dives, check out passthemsra.com.
And freemsra.com for additional valuable resources too.
Keep up the great work with your revision.
That's all for this deep dive. Best of luck with your MSRA prep, and we'll catch you on the next one.